now going to begin by introducing our first speaker also from Sydney, Australia, and that is Chin-Lu Cheng, who is a health economist at the Kirby Institute at the University of New South Wales. Over to you, Chin-Lu.
Thanks, Virginia. I'll start sharing my screen. Hi, everyone. My name is Chin-Lu. I'm a research fellow at Kirby Institute, UNSW. Today, I would like to talk about a financing incidence analysis conducted over a 5-year period. In this analysis, we try to answer the question, who pays for healthcare in Indonesia? Indonesia is the world's largest archipelagic country. It consists of over 17,000 islands and is home to over 270 million inhabitants. Indonesia is also the largest economy in Southeast Asia. It was upgraded to upper middle income country by the World Bank in 2020. Fueled by its strong economic growth, Indonesia launched its national health insurance scheme called JKN in 2014. By 2019, over 84% of the population was already covered by the national health insurance scheme. Indonesia aimed to reach universal health coverage in 2024. Since the implementation of JKN, the health funding structure in Indonesia has changed quite a bit. Although out-of-pocket payments remain the largest contributor to total health expenditure, and social health insurance is contributing more and more towards total health expenditure. In 2018, social health insurance is the third largest contributor and take up around 23%. However, to maintain a healthy and sustainable health financing system, we should not only focus on sustainable funding, but also take equity into account. By definition, in a progressive or fair health financing system, the rich is expected to pay a larger proportion of the income than the poor on healthcare payments. If the poor is contributing a larger proportion of their income than the rich on healthcare payments, then we would say this health financing system is regressive, which is also unfair. The last study that assessed whether the health financing system in Indonesia was progressive or not was conducted over a decade ago. Since then, there's no further evidence on who pays for healthcare in Indonesia. Therefore, our study aimed to fill this gap and to measure how the burden of the health financing is distributed across different socio-economic groups in the JKN era. The approach adopted by our study is called financing incidence analysis, which is also known as progressivity analysis. It is a common measure of equity in health financing. In our study, we first assess the progressivity of individual financing sources, and then assess the overall progressivity of health financing in Indonesia. The major data source we used is called the National Socio-Economic Survey, the NAS. This annual survey collected vital information on household consumption expenditure. We also used some information from the 5th wave of Indonesian Family Life Survey. This survey not only collects information on household consumption, but also collect data on household income. We also used the National Health Accounts report from Ministry of Health and budget reports from Ministry of Finance to derive the proportional contributions of individual financing source. To assess the progressivity, we first calculated the Gini index based on ability to pay. We also calculated the concentration index for each source of health financing. Based on these two indexes, we calculated the Kakwani index. If the Kakwani index is positive, it suggests that this health financing source is progressive. If negative, it suggests that this financing source is regressive. And here are the preliminary results from our study. Indirect tax payments, social health insurance, company health coverage are all regressive from 2015 to 2019. On the other hand, direct tax payments and out-of-pocket payments were progressive. Private health insurance was progressive in 2015 and 2016, but became regressive afterwards. The overall health financing in Indonesia was slightly regressive over the 5-year period. So our study found that direct tax payments were progressive in Indonesia, which is consistent with findings from other countries. However, it is not progressive enough. In other countries, direct tax payments are usually the main driver for overall progressivity. Indirect tax payments were found to be regressive, which is somehow expected. This is probably because indirect tax payments, such as value-added tax and excise tax, are levied equally on everyone, which means that the poor households will pay a larger proportion of income on indirect tax payments compared with the rich households. Social health insurance is also found to be regressive. This is probably because at the moment, the Indonesian government is charging a flat rate of income for everyone, and also imposing a monthly salary cap at 1 million rupiah, which also means that the poor households are contributing a larger proportion of the income on social health insurance payments than the rich households. Out-of-pocket payments are progressive throughout the 5-year period, but the progressivity decreases over years. And this is probably because since the implementation of JKN, the top 20% of the population are contributing less out-of-pocket payments, while for the bottom 20% of the population, their shares of out-of-pocket payments remain similar over years. And our study has not fully finished. We're now estimating the corporate income tax and will include indirect tax payments. So our results might change in the end. We're also conducting a series of sensitivity analysis to test different scenarios and assumptions we made in the study. We're also going to provide ongoing feedback to stakeholders such as policymakers in Indonesia to help identify key areas that need further attention when we progress towards universal health coverage. I'd like to acknowledge the founding organizations and our project team members. And that's all for my presentation today. Thank you.
Great. Thank you very much, Chinlu. And I should just remind everybody that, of course, these presentations are all accessible now. And you can, if you haven't already, have a closer look at the 20-minute presentations that each of our presenters have put together for our benefit. Okay, so moving straight on now, we're going to go to Kabaso Malenga, who's from the University of Witwatersrand in Johannesburg, South Africa. Over to you, Kabaso.
Thank you very much. Sorry for the delay. It's technology and the like. So my name is Mlenga Kabaso, as Virginia has already mentioned, and I'm a PhD student at the University of Witwatersrand. I'm going to share a paper called Socio-Economic Inequality in Household Willingness to Pay for Social Health Insurance in Zambia. Well, for those that know very little about Zambia, Zambia is a landlocked country found in Southern Africa. Well, we have a population of about 18 million people, and we depend mostly on copper. Then in terms of health financing, we depend mostly on donor funds, which accounts for something like 47% of the funding to the sector. As a brief background, because of the poor, in terms of low insurance coverage amongst the people, and the fact that the health sector is underfunded, the government of Zambia in 2019 decided to implement what is called the social health insurance scheme. The plan was to roll it out in 2 phases, starting with public and formal sector employees. In our study, we are trying to just look at the willingness to pay for this program as far as the general populace is concerned. And we are trying to examine, of course, the inequalities in willingness to pay for this scheme, which has never been done according to the best of our knowledge. And we believe that doing so will provide with the policymakers with the necessary tools with which to address these inequalities. Specifically, we are trying to explore socio-economic inequalities in household willingness to pay for the newly introduced social health insurance scheme. And we, of course, have three main specific objectives. The first one is just to find the association between ability to pay and willingness to pay. The second is to document the extent of socio-economic inequalities in household willingness to pay. And the last objective is to determine the factors that contribute to this socio-economic in household willingness to pay. In terms of data, we are using the Zambia Household Health Expenditure and Utilization Survey, which has a national representation. It has about 12,000 households and 59,500 individuals. But I have to mention that the study is based on household data. Then willingness to pay was elicited in this data set using the bidding game version of contingent evaluation. And the first question was a binary question where the household was asked whether they are willing to pay or not. And the other questions for those households that were willing to pay, 9 iterations were asked of the bidding game, starting with 3,000, and the list was 10,000 kwacha. In terms of the three objectives, for the first one, where we aimed to determine the association between ability to pay and household willingness to pay, we used 3 methods: interval regression model, Tobit model, and logistic model. And the main reason is because of the associated hypothetical biases that are inherent in the contingent valuation as a way of eliciting willingness to pay. The second, where we aimed to document the extent of socioeconomic inequalities, we did this by concentration indexes and concentration curves. And in order to determine the factors that contribute to these inequalities, we used the non-linear Okaka decomposition by Powers 2011 and the Wagstaff decomposition. And in terms of the results, for the first objective, where we were looking at ability to pay and willingness to pay, I must make mention that ability to pay was proxied by household expenditure. And we found that in all the models, ability to pay was positively related to willingness to pay for this scheme. Then in terms of documenting the inequalities, we found that in both the stated willingness to pay, that is where we use the absolute value, and the binary willingness to pay, we found that the concentration indexes were both positive. And we also discovered that the concentration curves were below the line of 45, which of course just shows that willingness to pay for this scheme is highly concentrated amongst affluent households. And this is desirable because we would like to see that cross-subsidization from rich households to poor households. Then in terms of the factors that contribute to this willingness to pay, like I said, the first one was by Powers, where we decompose the difference between willingness to pay between rich and poor households. The factors that contribute mainly to these, of course, are the ones that appear in the table, as you can see. And most of it is attributed to a place of residence, which in this case, of course, was written as urban. Then when we use the Wagstaff decomposition, where we decompose the concentration indexes, we discovered that the contributing factors are the ones shown in that table, but mostly you find that the percentage contribution, which as expected, is mainly explained by expenditure, which in this case is a proxy for socioeconomic inequality. And just lastly, as a way of recommendations, we thought of just recommending that the fact that ability to pay is positively related to willingness to pay. So we thought contributions should be set according to ability to pay. It could be through a sliding scale, or it could be a way where you give subsidies and exemptions, especially to poor or vulnerable groups. The other thing also, the fact that expenditure explains inequalities in willingness to pay, especially according to the Wagstaff. Well, then the government needs to create employment and income generating activities that absorb everyone, regardless of economic status. As you had seen also, other factors that contributed to inequalities in willingness to pay were things like education, marital status and the like. And we urge, of course, the government to promote adult and women education. Lastly, but not the least, but the most important, is that the fact that access to health insurance is also limited then we would also urge the government to also increase access of health insurance for especially the uninsured. Well, that is all that I had for you. Thank you very much. And let's hear from the next presenter.
Thank you, Kabaso. Thank you very much. And our presenters are very well at the time, so thanks for that. Now we're going to go on to Jacob Navigna, and welcome you. Jacob is from the University of Science and Technology in Ghana. Thanks, Jacob.
Thank you, Virginia. Yes, so I'm Jacob. I'll be presenting on exemptions, on the topic exemptions for the poor or the rich, an assessment of socio-economic inequalities in Ghana's national health insurance exemption policies. I did this with my colleagues Yao and Gokan. So universal health coverage remains a global policy target, and that is reasonable in the sense that, especially across many developing countries, health financing remains a challenge with high levels of out-of-pocket payments for health and largely underdeveloped insurance systems, which places extra burden on the population in the attempt to pay for healthcare. In Ghana, the national health insurance is considered an important step towards achieving universal health coverage to provide healthcare, affordable healthcare to as many people as possible, and removing financial barriers to healthcare. The health insurance system in Ghana is uniquely designed in a particular way, which is to provide exemptions for particular people in the population, especially those who are poor and vulnerable. And the idea is to improve equity in healthcare financing in the population. Unfortunately, there has not been any study to evaluate these particular exemption policies. And so our study tries to analyze the level of inequality in these exemption policies. And I'm going to tell you a little bit about these particular policies. So the scheme in general started operation in 2004, and it's largely funded through the National Health Insurance Fund, which also depends heavily on the National Health Insurance Levy, a portion of value-added tax. Currently, there's about 40% of the population covered by the scheme, and in terms of exemptions, it's designed in two levels. There is a level of exemption that requires individuals to only pay processing fees, but not premiums. And then there is also the level of exemption that exempts individuals from paying both premiums and processing fees. So these are indigents, people who are considered to be poor, and also pregnant women, as well as LEAP beneficiaries. So we split these exemption policies up and identify individuals who benefit from the health insurance scheme through these exemptions, and try to see whether there is any differences or inequalities in terms of well-being in assessing the health insurance or benefiting from the health insurance system. To do this, we use largely famous techniques, which my colleagues have discussed earlier, so I'm not going to go too much into it. The concentration curves to give a pictorial evidence of inequality, and then the concentration indices to try and compute the magnitude of inequality across the different groups. We used the largest socioeconomic data sets in Ghana, the Ghana Living Standard Survey, 2 rounds of the survey, the 6th and the 7th round, and we relied on variables that try to identify the specific exemption categories across the population. We looked at 5 different exemption categories. The general exemption, which covers everybody who is exempted, exemption as indigent, which covers individuals identified as indigents and exempted, and then exemption for individuals under 18, as well as exemption for the aged, and then finally exemption for pregnant women, which is the free maternal service program, which targets covering women who are pregnant for prenatal and postnatal care. In terms of wealth status, we used real total household expenditure adjusted for adult equivalent scale. So the results suggest that in general, the health insurance exemption scheme is concentrated mostly amongst the poor from the concentration curves. And if we break this down to the specific exemption policies, we see that for each of the exemption policies, exemption is concentrated amongst the poor. So for the aged, it's concentrated among the poor, as well as for pregnant women, the free maternal service, and then for indigents, mostly concentrated amongst the poor. Now, what we do is then to try and compute the magnitude of inequality. In general, we see that the level of exemption is concentrated amongst the poor, but then there are some interesting dynamics that happens in the latest round of the survey. We found that for exemption as indigents and exemption for under 18 or children under 18, we find that in fact it was only people in rural areas who drive the general inequality that favors the poor. And for under 18s, it is generally people in urban areas that drive the inequality in this particular category. Same situation happens for the aged and for the free maternal service in this case. Now, what is interesting here is that for the exemption categories that show only statistical significance in rural areas, that is the exemption for the indigents and exemption for the free maternal service. These are the exemptions that do not require individuals to pay either the processing fee or the premiums. On the other hand, the exemptions that we found to be only statistically significant in urban locations, these are the exemptions that require individuals to pay at least some processing fee. And this is interesting because in rural areas, even though these processing fees are considered to be very minimal, they could actually make a lot of difference. They could deter people from either, even though they are exempted, subscribing to the scheme, or failure to renew because they may not have sufficient funds to renew, even though they may be exempted. And this is quite interesting to observe. However, the general exemption categories was found to be significant and consistent across both rural and urban populations. Now, these findings obviously raise some interesting policy discussions, and one of them is the need to maybe target specific types of individuals and not generalize exemption policies, even though they are very interesting and important policy options to be considered. My colleague from Zambia, when he was speaking, proposed that there may be need to exempt some groups of people, but the evidence here suggests that such exemptions should not be general, should not be one size fits all. It may be important to target specific people with specific exemptions. For example, ensuring that people in rural areas, even though they may qualify for particular exemptions like those under 18 and those who are aged above the age of 70, they may also be exempted from paying even the processing fee that is required, whilst people living in urban areas who may be more able to afford these processing fees actually go ahead and pay such processing fees. Thank you very much for your attention. This is just a summary of my presentation.
Great. Thank you very much. All right, we're starting to get a few questions in the chat box. Maybe we'll move swiftly on to our final presentation by Alameu Helu from the University of Bergen, but originally from Addis and the Ministry of Health in Ethiopia. Over to you.
Thank you, Virginia, and thank you all for coming to this session. And I will be talking on equity in public health spending in Ethiopia. And I did this study with my colleagues, Roman and Ola Norheim from University of Bergen. To best use of your time, I will briefly introduce the health system in Ethiopia and the objective of my study, and I will talk on the method, and I will mainly focus on key findings and conclusion. Therefore, Ethiopia is a big country, the second most populous country in Africa, with now nearly 120 million population, and but the health expenditure per capita is very low. It's about $32 per capita. And the health system is organized into three-tier system. The first level is primary health care unit, which which contains health posts, health centers, and primary hospitals. And the second level has general hospital, which provide more advanced service. And the third level is tertiary level hospital located in major big cities and which provide specialized care. After saying this, the research question you want to address is which socioeconomic group benefit more from public health spending in Ethiopia. And as you all agree, I think expenditure on public health should be proper. There is a wide consensus in, I think, in this statement. And if it's not proper, or in any case, we need to monitor. And if it's not proper, we need to make appropriate remedial action to make it more proper. And in this study, we also explain, or we try to explore more why the public health expenditure was proper or was not proper. Then we applied the benefit incidence analysis, and we applied the standard approach of the benefit incidence analysis, and you can read the detail of the method from McIntyre and Ataguba paper. It's well explained in this paper. And we did this study in 2-3 years back, but the analysis was done for 2016-2017, or based on the Ethiopian fiscal year for 2008 Ethiopian fiscal year. Now we are in 2013 in Ethiopian fiscal year. And we use 3 data sources: the Living Standard Measurement Survey, Health Management Information System, HMIS data from the Ministry of Health, and from the Ministry of Finance, we also use the financial expenditure data. So we followed these steps for the benefit incidence analysis, and we aggregate the health service utilization and associated health expenditure for that health service utilization across individuals and across different income and socioeconomic groups. And we calculate the unit subsidies using the ratio of the health service utilization, that specific types of health service utilization, the expenditure to the service utilization. For example, for health center, we calculate the total expenditure on health center divided by the total utilization of health center service. And we try to aggregate this across groups. And this is the unit subsidy result we have. As you can see, the hospital services, unit subsidy at hospital services, nearly $100 for health center, and outpatient, it's relatively lower. When I come to the distributions of health service utilization result, as you can see, the lowest income quintile utilizes low proportions compared with the highest quintile. And we also try to see the decomposition analysis as the previous presenters also did. And you can see the contributions of residents, place of residence, being urban or rural is the key drivers of the health service utilization. The difference is mainly in that regard, but also age and socioeconomic status or wealth and gender also contribute to the inequality to some extent. And as this is again a very congested graph. It's very difficult to see but as you can see, most of the distribution seems very close to the line of equality. And we also try to see the concentration index decomposed into justifiable and control variables. When I come to the benefit incidence analysis result, you can see the total subsidy looks slightly pro-poor. It is above the diagonal. And if you see also the proportions of health service utilization across income quintile, you can see the lowest quintile, for example, in only use 4% of the total health service utilization, while the other groups more or less uses the same proportion. So in conclusion, the total public health spending in Ethiopia was marginally pro-poor. As we can see from this, it sounds marginally pro-poor. The total subsidy is above horizontal line, and the concentration index is also negative, but very close to zero. But public health spending at hospital and inpatient service was pro-rich. And therefore, this kind of study reveals that benefit incidence analysis without disaggregation by health service type or facility type or other subgroup analysis could mask essential disparities. And we then, as a recommendation, an effort is needed in making inpatient and hospital service more accessible to the lower quintiles. And we want to give emphasis to the inpatient care and hospital service. And I would like to thank the funding sources and my colleagues. Thank you so much. Back to you, Virginia.
Thank you very much. Really interesting results there. I'm going to now, we've got a nice sort of amount of time now to start looking at our questions that people, or comments that people have posted. I'm going to go through these just as they are, but you know, I've also got a few that I might insert myself along the way. So the first question here is for Kabaso. Thank you for an interesting presentation. You said that the survey used is a nationally representative one. However, many national surveys of this kind actually don't reach the poorest or the most marginalized. Is this something that you've thought about in your project? Do you know how well the survey you use does or doesn't cover these groups? So that's the first thing. And the second comment was, what is the coverage of the health insurance scheme? I think that first question is one that we all grapple with, both in terms of using secondary data sets, but also even in our own primary research when we're trying to look at equity of access and utilisation. It is a really important issue. Could we get your thoughts on that? Great question, Briony. Over to you, Kabaso.
Thank you very much, Briony, for the questions. No, you are very much right. I think the issue of national representation, especially in the African setup and Zambia in particular, is something that, of course, even if we say national, but it's very true that most of the marginalized groups are usually left out, and it's something that is inherent, I think, in when you're collecting data in Africa, because mostly you find that some places, first of all, are unreachable due to bad roads. You find the climate, some of them they're just unreachable, and in terms of the same data, you find that we depend on identifying the Cs and the CAS on the census, but like collecting sometimes data through census sometimes is also a problem. I can even assure you right now, the country was supposed to collect another census like last year. We don't know whether they have done that. We are not sure. So anything that is going to come out then from there is going to be a problem. So you are very much right that marginalized. I think that's something that we just have to maybe take as a limitation of most of these studies. And in as far as identifying that, I think when you are dealing with household data for African country like Zambia, it's something that you cannot, of course, overlook. Then in terms of coverage of the social health insurance scheme, so the social health insurance scheme at the moment has only covered something like 500,000 Zambians. It has only been rolled out to public sector workers because it's easy, obviously, to collect premiums from public sector workers. The ultimate goal is to extend to everyone. But of course, there are, of course, problems because already, like the mines, they already have their own kind of schemes. And they're saying, well, why should we then join this one? Because it will be double kind of deduction. And moreover, our schemes are much better than the one proposed by government. So at the moment, it's just about 500,000 public sector workers. Thank you very much.
Thank you, Kabaso. Maybe, Kabaso, just while we've got you there, I might just, if you don't mind, throw another question your way. And I think it's, yes, here we go. You recommended community-based health insurance, but this seems to have a low ability to generate resources in low-income settings, given that many rural populations are unable to contribute. I just, yeah, maybe we can, is it really therefore worth the effort? And that's from Moses, I think. Thank you.
Yes, thank you very much. No, you are very much right. I think the amount of resources that can be realized from CBHI, I think from evidence is quite low. But as they say, half a bread is better than the whole loaf. So the recommendation comes, we believe that CBHI, first of all, which is more or less non-existent in Zambia, unlike other countries. We think it's something that can just complement the now implemented social health insurance scheme, which also we estimated that it will not realize a lot of resources. So you are very much right that it may not realize that much, but we just feel that as a complement, it may provide that half a loaf that some of the vulnerable groups in Zambia might require. Thank you.
Thank you very much. Okay, we're going to switch back now to Chinlu's presentation. There's a comment here from Stephen Law. What is the proportion of Indonesian GDP contributed to the grey economy? Is it known that the grey, it is known that the grey economy is the main challenge in public finance for many low and middle income countries. For example, people living in rural and remote Indonesia are less likely to pay formal taxes, social and health insurance premiums than those in urban areas. And Chun Lu, feel free to cast this to your many Indonesian colleagues who are also participating in this session today. But we'll start with you, Chun Lu.
Thanks, Virginia. Thanks, Stephen, for the question. Sorry, I don't have an answer for the proportion before. I just did a quick search. I found a report by OECD like 10 years ago. It seems the informal sector is contributing around 30% towards the GDP, but that's a 10-year ago report. So I'm not sure how the proportions have changed recently. Yeah, what we said about the people living in rural area and remote districts are less likely to contribute to social insurance premium. But as far as I understand, the JKN is covering workers from informal sectors, even they are non-waged. But yeah, maybe I need to resort to my Indonesian colleagues for some comments and insights on this question.
Thank you. Thank you. I that's completely fair, I think. Could I maybe invite, I can see we've got Professor Hasbullah Rabbani, we've also got Fatah on the team. Prof, did you want to comment?
Yeah, for, in our system, the government pay contribution, we call it subsidized member. Currently, 45% poorest people are covered by the government. So they don't contribute at all. The government contribute. The amount that the government contribute is equivalent to the average claim cost per capita. So the government contribute per person per month. The national government contributes about 40% poorest, and some 5 to 10% additionally contributed by the local governments. Only those who are formal sector who have a monthly salary contribute from salary deductions, which is 5% of the salary up to the ceiling. The ceiling now is 12 million. So it's about $900 salary per month. So that's the way we ensure that the lowest income are covered. The right is the same, so they can have the benefit in public and private healthcare providers contracted by the National Health Insurance Scheme. Over.
Thank you very much. Thanks, Prof. I'm going to, I will do my best to come back to all the questions. I just want to make sure that each of our presenters have an opportunity to speak. We've got a comment here from Augustine Asante. Interesting presentation, Jacob. The exemption is a great policy, but targeting the right group has always been a problem. Targeting by rural, urban, age, etc. is good, but still problematic in many ways. What's the current debate in Ghana around how best to target those who really need to benefit from the exemption policy?
Thank you, Virginia. Thanks, Augustine, and good to see you here. Great question, but unfortunately, there is not much discussions around this at the moment. And I guess that there are several other challenges that seems to be taking attention, and not much is given to these exemption issues. And there was, of course, an earlier question on how much it's going to cost if we decide to maybe remove processing fees for the poor. And I haven't done that costing, but on average, this would be around $1 to $1.5 per head. And while this is really small for a poor village individual, that the opportunity cost of $1 is quite high. And so that discussion needs to be had, but unfortunately not much has happened so far. Thank you.
Okay, thanks, Jacob. I've got a question here to Alameyu, and it's from Peter. Thank you for a nice analysis. Have you tried to compare the distribution of benefits versus distribution of need? This is an important assessment as it captures the equity focus. Would you like to comment on that?
Yeah, thank you, Peter. I think this is a very important question. We didn't compare the need in this analysis, but the need is more likely to be high among the poor quintiles because of higher disease burden in that group. But we include in our analysis not only service related with treatment, but we also include, for example, immunization services, delivery service, all types of service were included, and we didn't want to do that kinds of analysis in this case. But that's, I think, very, very important to see also the need.
Mm-hmm. I don't think it probably would be overly difficult. I mean, obviously the measures of need, you know, it is complicated, but if you have from your data set, your national data set, if you have got some kind of indicator of need that you could use, it might definitely, I think that's a really good suggestion to explore that. I think your results are really interesting, particularly looking at the results for the distribution of benefits between, you know, the stark difference between the poorest group and then the one group up. They're very different, aren't they? And I'm not sure what is driving that, because the benefits to the second poorest group are almost up there with the highest income group. Is my interpretation correct?
Yeah, that's the finding we get. I mean, the poor are, I mean, the lowest quintile are completely left behind, and they don't even make any kinds of health service visit at all. This might be because, I mean, the health service in Ethiopia is relatively cheaper, but there is very small fee, nominal fee, and that fee can be also a barrier to the most poor.
Mm-hmm. Thank you.
Yeah, the lowest quintile in our analysis, even they don't see a health service visit at all, almost.
Thank you. There's a thank you very much. There's another question there's a couple for Kabasa, and this one is from Abe. Some of the factors considered, like age and those less than 18, are already fixed variables that cannot be changed with manipulation. So will it be sound to consider as variable because so far as an aged he or she will be eligible? So may we consider other factors that are embedded in the inequity or equity? I'm not sure. Is that something you can respond to, Kabasa, or do you need clarification?
Well, I suppose that is for Jacob. I don't remember.
Okay, yeah.
Yeah, I suppose this should be for Jacob.
Because,
I could be wrong.
Sorry, I was directed at you, but Jacob, would you like to comment? Is that clear, or do you need clarification?
I need some clarification, sorry. Could you just...
Okay, no problem. Abe, could you maybe take yourself off, turn your mic on, and maybe would you like to talk to your point?
Okay, thank you.
Thank you.
Yeah, by the way, his presentation was very excellent. And I learned a lot from his presentation, and you know, there were variables for the exemptions. Among the exemptions are, for example, If somebody is aged, he will be exempted. And if somebody is less than age 18, it's already exempted. If this is the criteria for eligibility to be exempted, obviously it is these factors are not easily we will not manipulate these factors. So will it exactly show the inequity? Because it's already fixed. Somebody if aged greater than 7, he will be eligible. So maybe can we take some other factors behind to show the inequity? That was my question, if he votes me.
Yeah, thank you, Abi. So yeah, if I understood correctly, the exemption is not automatic for most of these categories. Even for the free maternal service care, you would have to present at the facility and then you get registered. So across all the exemption categories, you need to get registered to have a card. But for some of these, the other categories like the under 18s and the aged, you need to pay a processing fee to actually get a card. So it's not automatic. It's a decision that you need to make. Even though the design says you are exempted, you need to go and then get yourself registered onto the scheme. Now that can be influenced by your socioeconomic background. And that's the point that we try to look at here. So even though you are aged and you are exempted, if you don't have that $1, $1.5 to go and pay to get the card, you are not covered by the scheme. So that's where we got the motivation from, to try and see whether in fact there is these socioeconomic differences in who eventually gets the card and gets registered on the particular exemption policy. I don't know if this answers your question. I got it clear.
Exactly, you got it. Thank you.
Thank you.
Thank you, Jacob. Thank you, Abe. Jacob, just to keep you going there, there's a comment from Naya Batura thanking you for your presentation. At the end, you recommended removal of some payments for vulnerable people, removal of, for example, the processing fees. Are these fees a very high proportion of what patients pay? And would these really represent a significant barrier? I guess I was also thinking along similar lines there. We often see that removal of fees are sort of have not always a major impact because of the size of other out-of-pocket payments. So just wondering if you could comment on that.
Yeah.
Thanks.
Yeah, that's a very important point. And I haven't really done any extensive work, or I've not extended the work to this level to see if removing such fees would still lead to any changes in terms of how much people pay. But the problem is, in most rural communities, people shy away from formal care because of out-of-pocket payments. So the idea of the health insurance is to try and bring these people into formal care by removing the barriers for care, which of course is financial. Some of them not, but mostly financial. So so the point is that if we do not get these people into formal care, they will seek other sources or would not come to seek for care. And that would lead to more devastating consequences. So the question really is not about whether they would still pay out of pocket if they don't take the insurance. The question is whether they'll come to seek the care that we need them to get. And like I mentioned earlier, even though these processing fees are very small, to some people, that's very relative. It's $1, $1.5, that's very relative. But to these poor rural folks, that is a lot of money. And if they have to pay that money to get registered onto the scheme, they would rather keep the money to do other things. That's the possibility. But like I said, we have not extended the study to that level yet. That's what I can say at this point. Thank you.
Thank you, Jacob. Thank you. We're running out of time. We've only got about 5 minutes. I'm going to try and squeeze in another question. I'm sorry if we don't get to all of them, but I really would encourage. It's so easy on the IHEA website to post messages to each other. If you just look up the person either through their presentation or as an individual in IHEA and post a comment to them, it'll be shared to their IHEA email address. So please do follow up especially if I don't manage to get to your question. I think, Cabasso, just coming back to you, great presentation again. Have you tried to check the correlation between ability to pay and willingness to pay separately for insured and uninsured? Can I throw that one your way?
Thank you, Peter. No, we haven't done that. And it's good that you brought it up. I think it will give us more insight because we aggregated all insured and uninsured. I think we'll definitely take it up and disagree the two. Thank you.
Thank you, Basso. I won't be able to get to it now, but just underneath that comment in the chat box is another point that is made by Lisa. I just wonder if you have a chance to have a look at that. You might want to post a response or speak to her. And I apologize that we couldn't get to everybody's questions, but before everyone leaves, I would like to say a big thank you to all of our presenters. I'm sure you'll agree, wonderful presentations, and they're all available for you to access. And thanks again for really important comments and contributions to the discussion from our audience. You can evaluate the session on the website, so please do that after the session. And join, this session was organised by the Special Interest Group in Health Financing. Please join the SIG. We'd welcome all of you, and enjoy the rest of the conference. Thank you very much. Great session.